We've, in this era of COVID-19 as a pandemic, we've taken on significant responsibility in providing information to our clinics, and we've sought best practices from our clinics, and we're translating those into daily or near daily updates into what can be done in order to keep your staff safe, to transfer or translate your practice into an all virtual practice in the case that you find that the risk is too high, or if you have exposure to COVID-19 in the clinic, or if there are key personnel who become ill with the virus. We're trying to make sure that care doesn't get interrupted for patients, and that we can switch over to telemedicine sort of practices rather than shuttering the clinics altogether, so that our patients still get cared for. It's a terrible challenge that they face. As you likely know, many of our patients are immunocompromised based upon the medications that we use to treat their diseases. In fact, we have to provide medicines that compromise their immune systems in order to keep them from attacking themselves, from their immune system from attacking their bodies. And as such, it's a particularly high-risk population. We don't know the details of that, in that formal studies have not yet been done to assess the differences in risk between those on the medicines that we typically use to treat autoimmune diseases and those who aren't on those medications. In fact, oddly, some of the medicines that we typically use in the case of arthritis or autoimmune disease are now being held out as possible treatments for COVID-19 infections, although that data is in really nascent early stages and shouldn't be relied upon as anything but as anecdotal rays of further paths for further investigation rather than solutions to a problem. And there are a number of clinical trials going on across the country, and we have some efforts underway with some strategic partners to try to have a surveillance system through which we're going to attempt to identify differences. For instance, if we find that a number of our patients get admitted to the hospital who are on certain medicines as opposed to other medicines, we might infer which drugs are helpful or which drugs could be a particular problem, and by the same token, which diseases are a particular problem from putting patients at risk for COVID infection. We have outreach from a number of our clinicians across the country in different scenarios. Some of them have had, out of best judgment and an abundance of caution, decided to switch to virtual only visits and not had face-to-face contact in their clinics any longer. And that's, some of them have had scenarios where hospital systems in their area are already being overwhelmed. For instance, I spoke with a good friend who was in clinic yesterday and had a patient who was experiencing a stroke as she was seeing the patient. Problem was, as she called around to emergency rooms to get this patient appropriately triaged and treated, a number of the emergency rooms refused to take the patient because they were overwhelmed by patients largely with COVID infections or possible COVID infection. And so she spent 2 hours in clinic attempting to find somewhere to get this poor woman to be treated who was having a stroke. So there are a number of challenges, both from just exposures. That is to say, if a patient comes in and has a concern over a possible exposure, or a patient comes into clinic, we've already missed an opportunity to screen effectively. What we all need to be doing is getting ahead of the game, calling, reaching out to patients, or using video conferencing to reach out to patients, and screening the list of patients who are coming into the clinic before they ever show up. Because the best way to keep your staff safe, the best way to avoid transmission and getting COVID infection is never to come across it. So having patients check their temperature before they leave their house to ever come to your clinic, screening the patients with a pre-visit phone call to see if they've had fever, shortness of breath, or cough. These are some of the methods that we're using. When they arrive, we recommend that out in the parking lot that they text you and say that I'm here, and have a staff member in appropriate protective gear go out to their car, roll down the window, and check their temperature. If they have no evidence of fever, then we'll text them from the front office of our clinics and tell them when it's time to come into the waiting room. As you imagine, we're trying to practice appropriate spacing in our clinics to eliminate spread, and the social distancing should continue through our waiting rooms so that there's 6 feet between patients. That's required us to remove a number of chairs from the typical waiting room scenario, and this is why we have people wait in their cars until they're next up or the third in line to be seen, so that we don't have crowding in the waiting room.